Welcome back, everyone. By the way, thank you. You could have gone one of three ways. Thank you in the room for coming this way, so to speak. You've recovered after your speed networking, I see. There's a little bit of caffeine going through your veins. Thank you for throwing yourselves into that first session. Thank you for being in the room here in Singapore, and greetings joining us online or catching up afterwards. This is one of the three breakout sessions, second half of our first morning together today. This is a really important session about targets. By the way, before I introduce the session, I just wanted to give you a tip-off, and some of you will say, why didn't you say that earlier, Ollie? But when we break for coffee, and I think some of our refreshments throughout our time together, there are two stations at either end of our building here at Seri, so feel free to divide and conquer to cut those queues down. Sorry, bit of housekeeping, but really important. This is a session on targets, because the targets that we're being set, I think it's fair to say, it's not for me to say, this will be explained by others, but there are really critical gaps in quality and quantity when it comes to those targets set by the WHO. So the question is, what are our individual roles in addressing those gaps? So we're going to have some provocation on the data, what the data's telling us. But I thought it would be helpful maybe just to introduce someone familiar to you because of their role, certainly chairing the board at the IAPB itself, but maybe to set the scene, say why we need a session on targets. So before we introduce all of the other guests, let's set the scene with someone who needs little introduction. Please welcome up Babar Qureshi. Babar.
Well, good morning, everyone. Lovely to see you again after last year in Dubai. And a lot has happened since we all met face-to-face in Dubai. And what you're going to see here and what we're going to be talking about is the global targets, which would actually go up to 2030, and to see how do we collectively work towards them. And the session that is there is actually to look at what is our role. So we do know now the targets. Some of us who were present, and you would know that the WHO published the 2030 coverage targets last year, and those targets are available, and I'll allude to that on a different slide. But then how do we work together to ensure that we meet those targets? So this session is going to be addressing some of those very important issues. And what are those targets that we are talking about? We're looking at cataract surgical coverage, and which is a 30% increase. And that's not only cataract surgical coverage, but an effective cataract surgical coverage. And I'm sure Stuart is going to allude to it in his presentation. And we're also looking at 40% point increase in effective coverage of refractive errors. So those are the two major global targets we'll be looking at as we progress towards 2030. The content of this session, we'll have Stuart first to come up and talk about the WHO global targets and what data tells us. And I think a huge amount of work has gone in to already collect a lot of data to see where we currently stand, and then to be able to monitor it over time so that we can actually report against it. And then we're going to have three other speakers who would be looking at and sharing with us what are the different issues involved in looking at these targets. And we've got Jeffrey Webelembo, we've got Jacqueline Ramke, and we've got Antia from the IAPB. And I just wanted to also point out that if you're going to be looking for these resources, where to find them. Because we talk about a lot of these things, and they're all available online. So if you would go on to either the IAPB Knowledge Hub or the Vision Atlas, you would find most of the stuff that is already there, or even the IAPB Vision Atlas, where you can find all these things. I think with that, I don't want to take too much of the time at the beginning because we have a lot to go through. So with that, Ollie, shall I hand over back to you?
Thank you very much, Baba. Thank you. Thanks, Arthur. So the challenge we've got, I'm not 100% convinced I'm on here, but there you go. The challenge we've got is we've set our contributors very tight schedules. We could listen to them for literally an hour each, but we've given, I think, Stuart 10 minutes and our other contributors about 7 minutes each. So please welcome to the stage someone who's a technical officer within the Vision and Eye Care Programme at the WHO. Welcome, Dr. Stuart Keel. Stuart.
Thank you, Ollie. Thank you, Baba. Thank you very much. Pleasure to be here. So I'll get straight into it. Over the next 10 minutes, I want to cover 4 key topics. And firstly, to introduce the global targets, make sure everyone is clear on what the global targets are, what they mean, and what we're striving to achieve. The second is introducing the key results from the report that Baba mentioned, and this is the first report that provides us with some baseline values for these indicators. Third is looking at data availability and where are we now, where do we need to be with data availability, and what are the next steps. So getting into point 1 on the introduction to the global targets. So as Baba mentioned, in 2021, member states unanimously endorsed 2 new global eye care targets, their tracer, for 2 tracer indicators at the 74th World Health Assembly. And these are a 40% percentage point increase in effective coverage of refractive error by 2030, and a 30 percentage point increase in effective coverage of cataract surgery by 2030. So I emphasise the words percentage point increase. So what this means, as an example, if effective coverage of cataract surgery is 20% in 2020, then we're aiming for a 50% coverage in 2030. Another point I want to emphasise is the refractive error target encompasses both near and distance refractive error coverage. Why these indicators have been chosen as global tracer indicators for eye care, and the first point is very important. These indicators are linked to 2 of the most cost-effective interventions, not only in eye care, but in the health sector in general. They're also linked to consider different segments of the population across the life course. We know refractive error is very important from early childhood through to older adulthood, and cataract is a very sensitive indicator in the older population. And there's a huge unmet need for care. We'll see this in the results that I present very soon, but we know that universally, uncorrected refractive error, unoperated cataract are the leading causes of vision impairment and blindness globally. And for these reasons, these indicators are not just important indicators to monitor global progress in eye care, but also they're very good indicators to monitor universal health coverage in general. And in line with this, these effective coverage indicators are WHO's preferred indicators to monitor universal health coverage for 2 reasons. Because they don't just capture the extent of coverage of an intervention, but also the context or the content of effective coverage, which means that of those who receive the intervention need to receive the intervention of a sufficient quality to produce the desired outcome, which in this case is bringing someone from vision impaired to not vision impaired. So let's look at now the key results from the WHO's first baseline report. And I want to emphasise first, this baseline report is very significant. It's significant for a couple of reasons, because without data, there's no visibility, and without visibility, there is absolutely no action, and we are forgotten in eye care. So this is a very good starting point for us. It provides a reference point to begin monitoring progress towards the global targets, but it also outlines gaps in data that we need to focus on in the future. The first result I wanted to focus on is the global result. And the globally effective cataract surgery coverage in the population aged 50 years and over was 17.2%. So what this actually means is that less than 20% of people with a vision impairment due to cataract have actually received cataract surgery and had a resultant good quality outcome. So quite a sobering statistic. Secondly, the equivalent figure for effective refractive error coverage was 35.7%. So what this means is just over 1/3 of people who have a distance vision impairment due to refractive error have received a good quality pair of spectacles that corrects them to a point that they no longer have vision impairment. I wanted to briefly look at a couple of other results, including the income level results. And as you can see from the slide here, there is a clear trend towards increasing effective coverage and increasing World Bank income level. Specifically, effective coverage of cataract surgery and effective coverage of refractive error range from 60% and 90% respectively in high income category to lower than 15% in the low income category. So for refractive error, this is a 6-fold difference between high income and low income category. The next result I wanted to highlight is the quality gap. So these indicators really provide us with a unique opportunity to look at the difference between coverage and effective coverage that I mentioned before. And this is very important. And the reason why it's important, because interventions to bridge the quantity versus the quality gap are very different, as we know, require a different focus, require a different investment. So looking at the effective cataract surgery coverage gap here, the difference between coverage and effective coverage was 33.9%. So what this means is about 1/3 of people who underwent cataract surgery did so, but did not achieve a good quality visual acuity outcome. The equivalent figure for effective refractive error coverage was 7.3%, which is smaller but still quite notable. So they're the results. So these results really highlight to us, of course, that coverage of the most cost-effective eye care interventions are very low. We know that we have a huge challenge in front of us, but also a huge opportunity to scale up access to these very cost-effective interventions as we move towards achieving the global targets. So now what I want to focus on for the last 4 minutes is data. So where are we now with data? So let's have a look at the map. So this map shows us the distribution of data sources that were used in the report by region and by year in which the data was collected. As you can see, there's some quite notable regional variations ranging from 56 data sources available in the Western Pacific region to only 4 data sources available in the European region. So the important point here is to say that this is a good start for us. We have utilised, we have 175 surveys that we have from 62 countries. And since the report was launched, we've been able to add another 12 countries to this. So this is a good start. But as you can see from the map, there is really a lack of robust national data from most countries around the world. So let's now look at the opportunities that we have and the next steps. So the biggest opportunity arises from the UN General Assembly resolution on vision that was endorsed by member states in 2021. And what this resolution does is it requests for these 2 indicators specifically to be considered for inclusion within the SDG monitoring framework during the next round of revisions, which is in 2025. So the importance of this would be very notable, really raising the profile of eye care in the broader health and development agenda, number 1. Number 2, it stimulates governments and member states to collect and report data on these 2 indicators. And ultimately, number 3, it potentially leads to increases in people in countries including eye care within their universal health coverage packages. So what we know, though, is that there are several opportunities that we need to take to strengthen data. And the first opportunity we need to take is to collect systematic data more robustly and have good geographical coverage in data. What we also need is a better balance between national and subnational data. We know that a lot of the data that we have now is from subnational surveys that have been used for local planning purposes. But for these global surveillance purposes and to include these indicators within the global monitoring frameworks, we need a better balance of national data. Secondly, we need to address those regional gaps that we saw on the map before. In particular, we saw gaps in Europe and the Eastern Mediterranean regions. Thirdly, there are still some income level gaps, and interestingly, the biggest gap is in the high income category, and we're working towards addressing some of those gaps. Thirdly, we know we need to strengthen data in the younger population. For good reason, previous surveys have focused on collecting data in persons aged 40 and 50 years and older, But we know refractive error is very important and we need to collect data in the younger population. There are several methodologies. WHO is investing time and efforts in trying to increase the scope of methodologies in which we can collect data on these indicators by including these indicators within broader WHO surveys, including the STEP survey, the World Health Survey Plus, and soon to be launched sensory functions survey methodology. We know there are existing methodologies to collect data on these indicators, and we also need to take opportunities to include these indicators within broader general health, childhood and other health surveys so we can more robustly collect data on these indicators. So the next steps for WHO are really to increase the rollout of these epidemiological surveys that I just mentioned, and then prepare the case that we will put forward for inclusion of these indicators within the UHC and SDG monitoring frameworks. And in 2025, we will also produce the midterm report so we can continue to track progress towards the 2030 global targets. And with that, I will say thank you and happy to answer any questions. And also say that the report is downloadable from the WHO webpage and you can scan the barcode to access the report.
Thank you, Stuart. Why don't we have another round of thanks for Stuart Keel? Thank you very much, sir. Questions, and I can take those online as well if you have them. By the way, we have deep expertise in the auditorium, so we can go technical, but we also welcome relative newcomers to the sector. So stupid questions don't exist here. So if you'd like clarification on something, now's the time to ask. So we welcome that. I see your hand there. I see your hand there. I'm looking out for other hands. Just give me a sense of who would like to ask a question. Just please, we welcome them from anywhere. I've seen you there, sir. Looking around. Other questions? Just one sec. Hold on there, if that's all right. Yeah, okay, thank you. Anyone else want to ask? Because we've just got a couple of minutes for this. That's fine. Great. Please, feel free to say where you're from. It's good, isn't it? Right, here we are. We just come up on this mic just at the front. Stage right, please. Thank you.
Thank you for that great discussion and presenting those data. I'm Peter McIntosh from the University of Illinois. I'm a residency program director there, an ophthalmologist practicing. My question, and I'm new to all of this, so this is the first silly question. What is the accountability for member states to achieve the goals that you discussed?
Great question.
Yes, that is actually a very good question because it isn't an obvious answer. So these are unanimously endorsed targets. There was very strong support for these targets. Member states signed up to these targets. But this is a global target in the end. Countries actually move forward with setting their own targets, and we'll be monitoring progress at the global level towards these 30 and 40 percentage point increase. But quite often we'll find, and there's a strong push from the sector after the targets are endorsed to make sure to hold their countries accountable to achieving these targets. But countries can actually go ahead and set their own targets relative to these targets as well. So I think these are really global monitoring of these two targets. Countries quite often sign up to them, but also can actually set their own targets as well.
Mm-hmm. Very good question. Thank you. I saw another offer from in the room. Please step up to the mic. Anyone else in the auditorium, raise your hand. We've just got a couple of minutes for these. We might have more time. Thank you.
Thanks. Fantastic presentation. Kevin White from Global Vision 2020. My question relates to WHO, sort of like most large organizations, has these stovepipes of excellence. So the traffic safety report comes out with 1.25 million people die per year, educational outcomes, et cetera. None of those reports sort of link it to the vision issues. Would there be, or would you consider like an effort to sort of attribute some of those massive numbers of educational outcomes, traffic safety, et cetera, to the vision, or is there a way to do that?
Yep. So that's another very good question. So over the last couple of years, we have really worked on strengthening our work between the different departments. And you mentioned one with road safety, but there's also maternal child health. There's the program for older people. There's the NCD program, which is also very relevant. So it is very hard for us, given that most of the data that we get is attributed to a cause of vision impairment. it's very hard for us to, there's no reliable data out there that does segregate how many causes of accidents, for instance, are caused by a loss of vision. So that's a challenging one for us, but it is something we are discussing with the road safety, where we can create those linkages a bit stronger.
Okay, thank you, Stuart. May I have time for a final question, if I can see an appetite for it in the room? Looking around, free to raise your hand higher if I haven't spotted you. Do you see?
Someone at the back there.
Yes, fantastic. If you wouldn't mind coming down to our mic here, feel free to introduce yourself. This will be our final question for Stuart. Thank you.
I'm Mansour Rabiu, Noor Dubai Foundation, Dubai, UAE. Stuart, just want to confirm the effective refractive error coverage you mentioned for distance and near. What about for children? Does it also include that?
Yes, it's for whole population. It's for whole population. But of course, as I mentioned before, most of the data we have is in the older population, and it's very important that we now move forward with strengthening data in the younger population, not only the younger population, but also the working age population, because we know the impact of uncorrected refractive error on workplace productivity, etc.
Yeah, fantastic. No, really good. Stuart, forgive me for not knowing this. Are you able to be with us for the rest of the
Yes.
day? Yeah, brilliant.
Yes.
So if we might just ask Stuart more one-to-one for any follow-ups. But for now, can I just say thank you to Dr. Stuart Keel for your insights. Thank you very much. So I'll do the more formal introductions momentarily, but why don't we welcome up to the stage Babar, Jackie, Jeffrey and Anthea before I tell you exactly who they are and what they'll speak about. A round of applause as they join us on the stage. Thank you, please. Babar, Jackie, Jeffrey and Anthea, thank you. Okay, well, we've heard from Babar Qureshi already, from the IAPB. Next to Babar, we have Jacqueline Ramke. Jackie, welcome, from the ICEH, an associate professor at the International Centre for Eye Health in London, but also the School of Hygiene and Tropical Medicine and the School of Optometry and Vision Science at the University of Auckland. Welcome, Jackie Ramke. Next to Jackie is Jeffrey Willembo, who is the Medical Director for Eye Health and Neglected Diseases at Light for the World. And by no means least, Anthea Burnett, a knowledge consultant with the Fred Hollows Foundation and the IAPB. Welcome to all of them. Thank you very much for being with us. In order, and again, here's where our 7-minute clocks come in, forgive us in advance. Jackie will speak to us briefly about access, cataract and RE, followed by Jeffrey with some thoughts on quality cataract. So these are case studies. And finally, Anthea on quality RE case study as well. So we'll go back to back. Some supplementary questions from Babar, and then we open the floor in the room and online for your questions in the final piece of our session. So with apologies in advance for a minimal 7 minutes, please welcome up to the microphone Jackie Ramke. Welcome, Jackie.
Thanks very much, Ollie. It's fantastic to be here, and I've just had a really good time sort of meeting old friends and making some new ones. So thanks for the invitation to contribute to this session. Not so much a case study, but Jude asked us to sort of nominate 2 or 3 ideas that we wanted people to leave this session with, and so these are mine. The first is sort of a call to action in terms of generating and sharing knowledge on strategies as we begin to work towards these targets. A question really around whether there's anything to be gained by considering quality and access concurrently. And then a third idea around not forgetting financial protection and equity as we also pursue these quality and access targets. So I wanted to start by acknowledging my colleagues at ICEH, Ian McCormick, John Buchan and Matthew Burton, other colleagues at ICEH and around the world who've guided us in this work in the coverage space. And also a couple of things I'm going to talk about is drawing on working with a panel of several hundred people from more than 100 countries, so just acknowledging them as well. So first of all, a call to action, and I think this is sort of lining up with the opportunity that Ambassador Webson spoke about this morning in terms of evidence. So as we were pulling together the Lancet Commission, one of the activities we did was a Grand Challenges in Global Eye Health exercise, where we engaged more than 300 people from 100 countries to tell us, what is the key issue, and I think it's no surprise, improving demand and access for refractive error services, and then also improving cataract services in terms of quality, access and equity. And part of this, of course, is because of the large magnitude of the problem, but also possibly because where the systematic reviews have shown, we actually don't have a lot of evidence on how to bridge that gap between an intervention that we know works and people who need it. And even when we look specifically at this, and in terms of the evidence for population groups that we know to be underserved, we did some reviews on this, and of the intervention, the conditions considered in the evidence base for Indigenous populations and ethnic minorities, we found only a handful of studies looking at strategies to improve access to cataract and refractive error services compared to something like DR, which was looked at in much more detail. So I think sort of generating evidence in this space is obviously a big priority for us. My second, it's more of a question whether there's an opportunity to think about access and quality concurrently. So we have previously done a panel exercise working with almost 200 people to nominate priorities in terms of strategies to improve access, and we're currently doing it at the moment for quality. And we're using the quality framework, which I think has been adopted by WHO, and we've added planetary health to that. So we're sort of in the middle of that process. And one of the things that struck us is in analysing those results, looking from a quality perspective, many of the strategies that are sort of popping up on the screen at the moment are actually wins for access as well. So I don't know, just sort of posing a question whether there's opportunity for us to sort of think about quality, certainly in terms of improving the visual acuity outcome of surgery, but also to embrace these wider dimensions of quality. And a specific example of that, sort of drawing on the analysis that Stuart's already presented, there were a couple of countries when we, when we were doing the analysis that have more than 2 time points, and one of them was Nepal, that saw a more than 20% increase in their effective cataract surgical coverage rate in less than 10 years. And when we engaged with our colleagues in Nepal about the reasons for this, the main drivers that they nominated was sort of mandates that came into play in that time period that improved access or provided universal access to quality interventions. So everyone was receiving an IOL and everyone had biometry. And so these were sort of historically quality interventions, but it's the improvement of access that drove up the ECSC. And then the final point I was going to make is, so we've got this focus on access and quality, but not to sort of forget the other 2 dimensions of universal health coverage in terms of financial protection and equity. And Ian and I, a year or so back, supervised a master's student at ICH, and Kelvin was based in Hong Kong, and in his study he engaged 75 people from the Western Pacific region, 17 countries, and he asked them what are the most promising strategies to improve access to refractive error services in their country, and he asked that in terms of refraction and also in terms of accessing distance spectacles and near spectacles. 5 criteria that they prioritised on: reach, acceptability, sustainability, feasibility and equity. And the context of these countries and sort of the difference between financial protection for refraction and spectacles, I think most people would know this. 10 of the countries had universal access for refraction. 4 countries were providing financial protection for refraction. For some groups, they tended to be either people with vision impairment, older people, children, low socioeconomic status. 3 countries where we had participants from, there was no financial protection. It was quite different for spectacles. So 9 countries had some groups that had financial protection for glasses. There were fewer groups than there were for refraction, and 8 countries had absolutely none. So it's been really interesting attending the Refractive Error Working Group and seeing there's a lot going on in this space, and really looking forward to hearing about the SPECS initiative tomorrow. No time to go into what the strategies were, but there's lots of variations. You sort of appreciate participants from Australia and New Zealand having very different responses to the Pacific Islands or East Asian countries. But one thing that did come out was the need to reduce out-of-pocket costs, is particularly for distance glasses, and whether that was from public funding or public-private partnerships. So just wanted to flag that up, and I guess coming back again to Ambassador Webson's point about leaving no one behind, and I think, yeah, just to not forget, as we are making progress, particularly for on effective refractive error coverage, that there will be groups of people who, regardless of whether or not they get their first pair free, that will always need that assistance for the ongoing access to glasses. So thanks very much.
Thank you, Jackie. Now, Jackie, would you just I don't, you don't get away that easily. Don't worry, I've only got two super quick questions because I know Baba will have follow-ups. That Nepal example was fascinating. You're suggesting there that the implementation of those targets became a driving force.
No, because the progress, I guess, preceded the targets coming into play, but it's, I guess it was making the connection between a quality intervention, being intraocular lenses or biometry, which we know is improving quality, but it was I guess, a mandate that those interventions became accessible to everyone, yes, which was sort of nominated as the main driver.
Excellent. And finally, I don't want to miss the point that you were highlighting around planetary health as one of those considerations. Just say a little more about that, just so we're understanding what that's about.
So I guess it's just recognising, I think in the Commission we sort of did a piece on the large contribution to like I think the NHS as a massive provider of health services making a massive contribution to carbon dioxide emissions, and so there's an opportunity there that we do need to be mindful of.
Yeah, absolutely.
Moving forward.
Well, back to that point about everything being connected.
Yes.
Yeah, really helpful. Thank you very much indeed, Jackie Ramke. Thank you. So now we're going to hear a case study which I think will span at least 3 different countries, and it's a pleasure to welcome up to the stand Jeffrey Wabalembo. Welcome up, Jeffrey.
Yeah, morning everyone. Thank you to the organizers for giving me opportunity to share our case studies. I'd also like to use this same opportunity to acknowledge and thank the Austrian Ministry of Social Development that availed the resources to do these audits, and also to thank the leadership of the institutions where these audits were done. Usually it's not easy to gain access to this type of records, but they opened up their doors to us. So we were able to conduct audits in 3 countries, including Mozambique, Ethiopia, and Burkina Faso. It was at one institution in each of those countries. And for the rest of the presentation, I'll just refer to them as tiger, lion, and cheetah, so you don't have to focus your attention to any particular one of them. So the objectives included evaluating the status of eye health services delivered at these partner hospitals, and to assess the visual outcome of cataract surgery as a proxy indicator of quality, and then to identify improvement opportunities. We had key informant interviews that were held to collect qualitative and quantitative data about the eye health service status, including assessment of the number of staff available, equipment numbers, and status of the facility physical infrastructure. So the results from country which I refer to as Tiger, in 2021 the department had 25,897 consultations and 2,131 cataract surgeries. Audit was conducted on 186 of the 426 patients that were operated from 1st April to 30th of June. And the reason for that was that there was incomplete documentation on the rest of the patients. So only 186 could be analyzed. And here we had 54.3% males and 45.7% female that accessed cataract surgery. Yeah, I would like to draw your attention to the visual outcome. this is uncorrected. It's like presenting vision pre and post-operative. And if you look at the column of visual acuity at 6 weeks, we see that here we use, by the way, the previous threshold of 618, which was better known to the institutions than the current one of 612. So here we see that we're still running a little bit below the WHO expected or recommended standards of greater than 80% of vision 618 or better at 6 weeks. And we still had a rather high percentage of patients whose vision did not improve greatly, and they remained in the category of severe visual impairment. That's about 15.5%. Some of the identified opportunities for improvement here included, it was found that the ophthalmologist was responsible for a lot of administrative things and needed an administrator to assist in this. And then the system for documentation and archiving information needed improvement. All the numbers in terms of human resources were below the optimum for the level of service. The infrastructure clinical area was rather small for the number of patients that they were churning out. And then there were no equipment maintenance record available. While biometry was being done, the range of intraocular lenses available to the surgeons were limited. And then cost of surgery was also identified as a barrier to a cross-section of the population. And we noticed that there still exists a gender gap with more men accessing cataract surgery than the women. And then it was found that actually the number of surgeries carried out on the 1 day per week surgery was rather too big to ensure quality. And then the next country, which I referred to as Lion, we had the population catchment area served of being about 3.5 million people. And cataract surgical rate in that region was 1,506. So 445 eyes were analyzed for the surgeries done between February and April of 2022. And here again, we see that the male population was 52.8% compared to women 47.2%. Again, some important positive findings that this was one unit that had adequate human resources for all cadres, and this is rare in the developing countries, and had sufficient equipment level, courtesy of support from Light for the World. They had good and well-written clinical protocols which were being implemented, but still the visual outcome, as you can see, the column at 6 weeks was still running well below the expected standards. And then improvement opportunities here, we saw that the visual outcome is far below the standard, and there's a big loss to follow-up, which currently stands at 41% at 6 weeks. We found that one of the constraints was a constant supply of consumables, so they did not have adequate lens powers to be able to give patients what the patients needed, and the complication rate was also a bit, much higher than one would have desired. Improvement opportunities included ward space, which needed expansion. The hospital was crowded, and also to have equipment maintenance plans available or to be developed so that equipment is in good working order. And then the last country, there wasn't much by way of records available for cataract surgeries for that period. And so we didn't have information on the visual outcomes. So they also had similar constraints of stockouts and also the numbers of personnel were far below the requirement. Productivity per surgeon was also found to be less than desirable, and supply chain of consumables, as highlighted before, as unpredictable and inadequate, including essential documentation, which was lacking for many of the patients. Thank you.
Thank you very much indeed, Jeffrey. A very brief question. Dr. Stewart talked about the challenges getting data, particularly from a younger population. You talked about the male-female split. Any rhyming with what's been said there about access to data from young people?
Yeah, thank you. From the chart reviews, there wasn't much data on the younger population because most of the information was around cataracts, and there are very few pediatric cataracts in these units.
Yeah, so that really does resonate. Really helpful case studies. Thank you very much indeed, Jeffrey Wethelembo. Thank you so much. So our final case study comes from our colleague through IAPB, Anthea Burnett, who will speak to us again about quality RE, and we welcome Anthea to the stage now. Welcome, Anthea.
Thank you. So I'm here representing the Fred Hollows Foundation today, and we're talking about how we can better work together to meet the 2030 effective coverage targets. So we'd like to share one approach that we've been trialling to address the refractive error quality gaps. So in the context of effective refractive error coverage, there are three broad groups. We have the people that have their needs met. They have glasses, they have good visual acuity. We have the people that don't have any access to services. This is the coverage gap. Then we've got people that have access to services, but their glasses don't allow them to see as well as they should be able to. So this is the quality gap. So we really wanted to look at this aspect, and to do this we needed to look at facilities. We wanted to understand, if you went to your local optical store, what's the likelihood that you are going to be able to get a good quality pair of spectacles? So in order to look at this issue, we use the gold standard approach for measuring quality in clinical practice, which is to use unannounced standardised patients or mystery shoppers. So to do this, we recruited a variety of patients. We recruited patients with myopia, patients with hyperopia, with or without astigmatism, with presbyopia, as well as patients that didn't need spectacles. So we trained them in a standardised way to go out to optical services across the country, ask for an eye exam, purchase a pair of spectacles, observe the techniques that were being conducted in the optical store, and request a written prescription. These patients then returned to us, where we assessed whether the spectacles that they had purchased were optimal for their needs, according to defined tolerance limits. So we've done this study in 3 countries now, and we've been able to do this in Vietnam, Cambodia, and Pakistan. Now, the primary outcome of interest is spectacle quality, so that's the proportion of spectacles that are optimal for people's refractive error needs. So in Vietnam, just 27% of spectacles were optimal, with just 35% in Cambodia and 43% in Pakistan. Now, the secondary outcome in a QREX study are the associations between spectacle quality and patient characteristics, as well as between spectacle quality and optical service characteristics. And because we've got the information about the spectacles, we know what tests were performed because of the USP observations, and we've also got the written prescription, so we can really look at that circle and try and understand where there are opportunities to improve quality. So when we look specifically at the associations between spectacle quality, we found that people with astigmatism were much less likely to be prescribed optimal spectacles in both Cambodia and Vietnam. In Vietnam, it's probably because subjective testing for astigmatism wasn't performed. A lot of the spectacles that were not optimal in Cambodia and Pakistan was due to horizontal prism deviations. And in Cambodia, when people who didn't need glasses visited optical stores, at 44% of all of their visits, they were actually recommended spectacles that they didn't need. But this was mainly only true for women. Female emmetropes were much more likely to be unnecessarily recommended spectacles than their male counterparts. When we looked at dispensing across all 3 countries, we found that pupil distances were often not being measured and not being recorded on the written prescriptions. And in Cambodia particularly, the written prescriptions were really inconsistent. When we look at resources, In Cambodia, there was an over-reliance on auto-refraction, whereas in Pakistan, there was an over-reliance on the previous glasses that the patients wore when they went for the eye test. And we observed a real gender imbalance in refractive error workforce in Cambodia. It's a predominantly male workforce. In Vietnam, there were real inconsistencies in testing conditions. Sometimes visual acuity charts weren't used. People were just asked to look across the street at the window, and that was their visual acuity check. So it's all well and good to have this evidence, but we wanted to really make sure that the results from these studies we wanted to track whether the results have been used to influence practice and policy. So in Pakistan, these results have really accelerated improvements to the training of the optical and dispensers and mechanics courses. In Vietnam, it's really helped in the advocacy for the provision of the job code for optometry. A lot of people have been working on that for a very long time. QREX studies helped to just get that over the line. In Cambodia, the National Program for Eye Health has really embraced these results, and they're committed to introducing regulations in the public vision sector in the first instance. 60 to 70% of spectacles in Cambodia are provided in the private sector, so there's a real opportunity there to influence quality. But the private sector, in response to this research, has asked for more refresher training opportunities for staff. So how can we make this evidence work to meet the 2030 targets? A QREX study provides evidence about effective refractive error coverage gaps, but it can't be used to actually calculate EREC values. But it really does provide specific, practical and contextual findings and recommendations to increase access. So we actually think, to Jackie's point, we actually think it's crucial to fully explore and understand the complexities required to prescribe spectacles that are optimal for people's refractive error needs during any process of scaling up, while we're addressing access issues, so that the process of scaling up doesn't just create further quality gaps. So we're at the stage now where we would like to be able to share these tools so that more evidence can be generated on how to address the quality and quantity gaps to meet the 2030 targets. So we've got some tools available to do that. And I'd just like to acknowledge all the people that helped make these studies work. A lot of them are in this room, and also to the USPs who underwent so many refractions. Thank you very much.
Anthea, forgive me, I can't stop thinking about that 40% who were prescribed glasses who didn't need them. Just so I understand, did the prescription say that they needed them, or were they incorrectly diagnosed?
No, they're unnecessarily incorrectly prescribed spectacles that they don't really need. I mean, it's not a hard and fast threshold. Yeah. Yes, no. It's not a binary outcome.
Right.
It's very complex prescribing a pair of spectacles. Mm-hmm. I'm not an optometrist, by the way. But you can write on the prescription these people need spectacles that they don't really need.
Yeah, fascinating. Right, Anthea, thank you so much. Please have a seat. Now, Baba, we've got our work cut out because we've got 10 minutes, or just over 10 minutes. Baba, please chair us through, but then I'm ready and standing by to help us take questions from online as well. So please do flow those in as well, but also within the room. But Baba, I know you're going to have questions for our individual 3 contributors, so please.
Thank you, Ollie. I will. Just checking if the microphone is working. Yeah, okay, great. So let me start with Geoffrey. Geoffrey, you've just demonstrated very clearly that when you analyze the quality of cataract surgery, you actually are able to then see a lot of factors that contribute to that quality. I think one of the key challenges that we've faced is the whole culture of measurement of quality of cataract surgery. How do you think that we can improve that culture so that we begin to see more and more people recording their post-operative vision or the quality of cataract surgery?
Yeah, thank you very much. I think some of it is going to be advocacy work among the professional bodies, because there are now some softwares available for self-auditing, and this has some implication and influence in what someone does when they are operating. but also there's advocacy work at a wider level or a higher level, in that there are so many inputs involved in getting a good cataract surgery outcome. Like now, some of the countries, there is no, like the lenses are not part of the essential Ministry of Health inputs. Or even some of the inputs like viscoelastic are not part of the essential drug lists. So we need advocacy also at that higher level, policy level, to make sure that all the inputs that are required are available, but also increasing accountability on the in-video institutions and persons. Thank you.
Thank you. So basically, if there were national guidelines which were provided by the ophthalmic societies or by the national committees for blindness and visual impairment, they would at least help people to start monitoring their cataract surgical outcomes, which can be reported. Thank you. Moving on to Antia. That was very interesting actually to see the quality of refractive error and the sort of reasons why. And you said there are a lot of tools that you use and you piloted them in 3 countries. How do you think we can roll this out so that more countries can actually use these tools and we start getting the quality data on refractive error?
Thanks, Baba. Due to time, I flicked through a slide, but we've got quite a few tools available that we've developed. We've got the data collection tools for USPs, online training. All of this was done during COVID, so we had to pivot to online training. So we can teach a patient how to be a mystery patient. So we've got those tools available and we're happy to share them. We'd also love to see other people sort of take those tools and use them. A QX study is just about to be done in Malaysia, so we're really interested in the results coming out of that context. Can't wait to see. It's been a long time getting that Malaysia study happening, but it's just about to happen, so we're really excited about that.
Thank you. While I'm still asking questions, please, those of you in the audience who have questions, I think Ollie will ensure that we have enough.
Yeah. Are you ready for one now, Baba?
Just one
Yep.
I can take straight away.
Okay.
So this is Victoria.
Hi, nice to see you, Victoria.
Thank you. Thank you, everyone, for a wonderful presentation. In the presentations about the quality of cataract surgery, the suggestions to improve cataract surgery, from my observation, were pretty much administrative, logistical, and procurement. Was there any looking at pre-assessment of the patient? Perhaps the patient has lost a lot of vision from glaucoma, but they still do the cataract surgery anyway, so they're not going to get a good outcome. Or skills assessment, perhaps someone needs improvement in training. Is anyone looking at the clinical side of a poor outcome?
Yeah, great question.
Do you want to take that, Geoffrey? Go ahead.
Yeah, thank you for that question. For this particular audit, yes, there was, they looked into the pre-assessment, and this seemed to be well taken care of, but comorbidities were not easy to identify in the records. So some of the poor outcomes is not clear whether they are because of comorbidities or surgical skills. And also, as far as surgical skills are concerned, I think there's a general assumption that all people who finish their residency training are able to do good cataract surgery, but I'm not sure that there's any effort to actually document and monitor this at implementation level. I think that's a gap in itself. Thank you.
Mm.
So while someone else is getting ready, I'll ask a question to Jackie. And we've just heard quite a lot of information is currently out there. How do you think we can improve knowledge sharing amongst all the members of IAPB and others?
Thanks, Baba. So as part of the active afterlife of the Lancet Commission, we're looking at setting up live reviews that will, I guess, periodically identify in the scientific literature what people are publishing in terms of improving access or quality to cataract and refractive error services. But also I think there's a real opportunity to find a way of bringing together just knowledge and experiences from people implementing projects that may not make it into the scientific literature. So I think that's a real opportunity perhaps for Jude's team at the IAPB to find ways that we can perhaps have a platform to gather together that sort of information.
Thank you.
Great. Thank you, Jackie. The question in the middle. Feel free to introduce yourself.
Hello, my name is Hadi from Direct Aid Kuwait. We're an NGO that works in 30 African countries. I just wanted to pick your brains and kind of emphasize on the importance of partnerships in the ophthalmology and eye field. Direct Aid operates and does 1,000 operations approximately every month with cataract, but we kind of want to exceed that number and bring it to the next step and kind of help more people when it comes to saving, well, to me, essentially, saving your eye is saving your life if you can see the dangers and how you can survive. And I kind of wanted to see what you guys think about the importance of partnerships when it comes to the eye field, essentially. Thank you.
Great. Now, Baba, would you mind if we just took one? Was there an offer right at the back? Did I see that? Yeah, let's just take brief comments from the gentleman, yeah, and then the one behind you, and then we'll pass it back for a spread of those, if that's all right. Sir, and then the one right at the back. Do come forward, sir, so you're next in line, please. There you go. No, go for it. You're good. You're good. Thank you.
So thank you. My name is Jundak Tenzing. I'm from Seva Foundation. Thank you for sharing your data and regarding quality. I was just wondering, did you guys ask the patients about the quality of services?
Okay, great question. And just to your colleague behind you, and that'll be our final little range.
This is Dr. Rohit Khanna from Illi Prasad Eye Institute, Hyderabad. My question is like to the entire panel and Stuart and WHO and IPB entire group, like we have the indicators for monitoring cataracts like output, outcomes. We know how many surgeries being done in a country, what's the outcomes happening. Do we have any country where we have a system of collecting number of refractions done, number of quality of refraction, like is there a way we can get it done or make sure that we at least get annual outputs from the countries, from the hospitals, the quality of refraction, is there a way of checking that?
Good questions. Baba, are you happy to go back across them?
I'm going to sort of then spread them out over the panel. Let me just tackle the partnership question. I think the only way to increase quality cataract surgery is through partnerships. And the partnership can be between NGOs. It can be a public-private partnership with the government, because I always say the largest infrastructure to deliver eye health services in any country is the government. So a partnership with the government would always ensure that you have equitable and high quality cataract surgeries, specifically in eye health, all over the country. So partnerships are absolutely important and are critical to ensure that we do a huge amount of effective coverage of cataract. The second question that was there was on whether we have, whether the question was asked about the quality of services. Jeffrey, would you like to answer that?
Yeah, thank you very much. In this particular audit design, that bit was not included. However, one of the consultants who conducted the study, out of their own volition, did a small sample of asking patients, and that's how we managed to get the element of cost. They were feeling that the cost was leaving out a number of other people in the community who needed to benefit from surgery. But as far as outcome is concerned, that was not addressed to the clients. I think that would be a good question to address in future. Thank you.
Thank you. And then the last question was on refractive services and the quality of refractions coming out, whether we have national data. I'm going to look at you, Anthea, on that. That I know there were these three, because that's been quite a challenge getting that kind of quality data, I think, but let's ask Anthea.
I mean, that is essentially the point of a QREX study, is to try and understand what is the quality coming out of local facilities. You know, we have the effective refractive error coverage that provides a lot of information about coverage, quality and access. But that's what we were trying to address with QREC, is to really understand the drivers of any poor quality at a facility level and try and figure out a way to assess that in some type of standardized way.
Thank you. I think if I was just to quickly summarize this session, I think the important message is that we do have the targets now, and the targets are clear. And I'm very happy that Stuart really broke them down into a very simple way of what they really mean. But to be able to reach these targets, we all need to work together. And without working together, we would never be able to reach them. And by working together, we also need to be able to measure them. And that culture of measurement needs to come in, and the culture of sharing needs to happen, so that we all get to 2030 and say, yes, we have reached these targets that we set ourselves to achieve. Well, with that, Ollie?
Yeah, thank you very much indeed. But two things. Firstly, in fact, why don't we just take just 1 minute, because if I was Dr. Stuart Keel, I would probably want to make a couple of thoughts just at the end, if that's all right. Stuart, I know you've been, can I borrow that? Is that all right, Stuart? Can I sort of, because I think it's good to begin where we started, really.
Thank you very much, Ollie. So actually, I think it is a very good, I'll just come up. I think it's a very, very good opportunity to introduce a couple of items from WHO that I didn't get to mention in the presentation. Particularly after Jeffrey's presentation, where there was discussion on not having access to essential equipment, consumables for cataract surgery, for instance. And a key update from WHO over the course of the last couple of weeks is that priority medical devices for a range of eye care interventions, including cataract and refractive error, are now included within WHO's priority medical devices list. This is a more recent update, and really we hope that this can really stimulate increased priority of these devices moving forward. The other one is on facility level monitoring. Of course, I presented on population-based indicators, require population-based surveys, but WHO has also recently launched an eye care indicator menu and also a DHIS2, so District Health Information System software, that is currently used in about 80 countries very regularly, and this includes a number of eye care indicators. So this is ready to be integrated within health information systems. There's a number of cataract-related indicators included there. Refractive error indicators more challenging because the majority of services provided in the private sector. The last thing I want to emphasise is the change in thresholds to what WHO defines as a good quality visual acuity outcome. So we mentioned before, Jeffrey alluded to it, that previously WHO recommendations were a 618 visual acuity or better, but based on, these were set in the early 1990s, based on the advancements that have happened since then in technology, access to different types of surgery, of course these have been updated, and now the threshold is a 612 visual acuity or better for both interventions, but of course we can aim higher than this for refractive error.
Yeah. Great. Thank you very much indeed. Well, everyone, please join me in thanking, of course, Stuart, but also to Babar, to Jackie, to Jeffrey, and to Anthea. Thank you very much indeed. Thank you.